Hi class, so now we're at the last chapter in the book, chapter 16, Treatment of Psychological Disorders. And you'll see me again glancing over. I'm just looking at my notes because I want to make sure I cover everything in your kind of introduction or introductory film clips to these chapters. So in this particular chapter, we look at three major forms of treatments: biological, psychological, and integrative. As we do this, we'll be looking at different types of disorders and the treatments that are used with them. So first, biological treatments. These are drug therapies essentially, although we look at psychosurgery later on down the road as well. First, schizophrenia. That's the one that is probably the most challenging mental illness that's out there, most debilitating one there. Although some people would say that PTSD is certainly a factor, as well as some types of bipolar disorder, or the severity of the bipolar disorder. But nevertheless, schizophrenia. So traditional antipsychotics began in the 1950s, and diminishing hallucination, agitation, paranoia, based off of that dopamine theory. One of the concerns with these traditional antipsychotics, and Thorazine would be in fact one of those ones that fall in that category, is a thing called tardive dyskinesia. So tardive dyskinesia results in some facial tics, the tongue becomes harder. It's harder for them to pronounce words, and if not taken care of at the time, either reducing the medication or some other interventions, those can be irreparably an irreparable component of who that person is, so it never goes away. Then, fortunately, things improved in the area of pharmaceutical medicines to atypical antipsychotics. And so they block different dopamine receptors and have side effects that are fewer, less likely to create that tardive dyskinesia, which again can be there forever once it's there. Some side effects with it is weight gain, diabetes, reduction in white blood cells, a rare but possible form of cancer. Depression and anxiety disorders, MAO inhibitors are used, first used to treat depression. One of the problems with MAOIs is that they interact with foods, and so you have to get blood tests every so often to make sure that your levels are not too high. Then came the tricyclic antidepressants. Tricyclic because when you look at it from a chemical component, there's three parts of it, three stems that stand out, used for chronic pain, ADHD, bedwetting, as well as depression. Some side effects: dry mouth, weight gain, irritability, confusion, and constipation. Then there is the selective serotonin reuptakes, SSRIs, and those really have make the headway. Paxil, Prozac are all those examples of SSRIs, and essentially they block the reuptake of serotonin. Serotonin being a neurotransmitter that helps us feels good. Remember we talked about the last chapter that people with antisocial personality disorder are given antidepressants. That's because the serotonin levels are too low. And then there is also bupropion or Wellbutrin, and this inhibits the reuptake of norepinephrine and dopamine. Because some individuals, when you look at their depression, it's not just serotonin. It's these other areas as well, these other neurotransmitters that might be the factor and not serotonin. Anxiety disorders, benzodiazepines, highly addictive though. Barbiturates, they're calming, but there's again addictive and risk of overdose. Bipolar disorder, manic depression, regulated depressive episodes are prevented. Lithium is the drug that's primarily used for it, although you see more anticonvulsants used because of concerns about high levels of lithium in your system, but it's still used, and it works really well for some individuals. Anticonvulsants can work as well. Effectiveness, depression, SSR, and tricyclics, comparable effectiveness, although sometimes it takes up to 4 weeks for them to get into the blood system. Bipolar lithium still widely used, though weak effectiveness for acute phases, not superior to anticonvulsants or antipsychotics. Schizophrenia, traditional atypical work best on positive symptoms. Remember, those are the ones that we can see, for lack of a better term, the ones that we can see. The delusions, the hallucinations, but it does not seem to have as much effect on the negative symptoms, that flat affect. And there's certainly some unpleasant side effects, so patients often will stop taking them. ECT, electroconvulsive therapy, used with severe depression, very severe depression, and it can cause some relief. It's usually it's a treatment of last course, and the reason why is because there is memory loss associated with it. In fact, I had one client who, interesting client, she was a dental hygienist, if I recall correctly, and that's, it's like a year program to do that skill. Had severe depression, underwent ECT, and lost everything that she learned about dental hygiene. So there's some concerns. Psychosurgery. Remember we talked about trephination, chapter 1, I think it was. Prefrontal lobotomies. So rarely used nowadays. Electromagnetic therapies. Maybe some hope there. Not so much the ECT where you've got where you're going through one side of the brain to the other side of the brain. We now try to kind of detail where it's going. 12 sessions report some immediate relief. Side effect of the memory loss. We don't know how it works, but it does seem to help with severe depression. Transcranial magnetic stimulation. This is kind of interesting. This is where they're putting high power magnets on the brain, so it's not quite as dangerous as having an electrical current go through. Some help with severe depression. Again, not really sure how it works. They're not really sure how it works, so something moves me. Deep brain stimulation, which is kind of a new thing they're doing. They're putting implants in individuals' brain, and that way it's kind of like a pacemaker when it's, it kicks on every so often when it senses that there's a decrease in activity in that area, increasing that sense of wellness. Psychological treatments. There's a psychodynamic theory on uncover unconscious motivations, again with Freud, Jung, Karen Horney, Alfred Adler. They are all underneath that bent of psychoanalytical approach, specifically looking at the unconscious mind. Let's see, there's a humanistic therapy, which is, again, Carl Rogers is the one who's the most well known for this. And he talks about having a therapeutic environment where there is unconditional positive regard and empathy regardless of the client. He says that once you're in that atmosphere, the client then can resolve the conflicts that they're experiencing. He does have some really nice approaches to nice components of his theory that is used almost universally by counselors, and that is his ability to establish rapport. Behavioral treatments and other applying classical operant conditioning. We talked about that, punishments and reinforcements. Used to have token economies in the 1950s. Systematic desensitization is kind of a component as well. Behavioral treatments. Implosion therapy or flooding, which is not what I do. But what is nice about that systematic desensitization is you expose the client to things that are kind of like their fears. For example, if you had a specific phobia, you teach your client relaxation methods, and then you might have them in a spinning chair where anybody's going to get excited, and then have them relax. So they're learning those skills to calm themselves down. And then you might show them a picture of, say, they're afraid of dogs, picture of a dog, practice those relaxation things. Then they might show a video clip of a dog, practice those relaxation techniques. And so slowly you're shaping their behavior where they're actually able to interact with a dog or whatever their fear is in a way that it's not so severe. I like that as opposed to implosion. Implosion therapy or flooding is when you put somebody who's afraid of dogs and then just fill the room with 50 dogs. That's just not my approach to it, but it's a form of therapy out there. Cognitive behavioral therapy, that's what I do when I use a therapeutic approach. So cognitive therapy restructures irrational thought patterns. And so if somebody has an irrational fear of going outside because they're not going to be able to breathe, Well, we talk about that. We look at it from a cognitive perspective, what's going on in your mind to kind of support this process of this fear. And then we also have a behavioral approach, and that's where they might just open the door. So it's kind of like that behavioral approach we just talked about, systematic desensitization, but there's also the cognitive component to it as well. And Socratic dialogue is a key component of that. Then the text talks about group therapies, people sharing a common problem, and group therapies work really well for specific problems. Yalom, he is the guy who really got things going with group therapy. He would disagree with me. He would say that it could work for anything. But I found it works really well for some groups, for some unique problems. Like, for example, it worked really well for sex offenders. It worked really well for people that have had some trauma in their life. It's worked really well for people that have anxiety disorders, social phobias especially, because it gives them a safe place to practice their skills. Most therapies, let me rephrase that. All therapies that are going to be practiced by a licensed psychologist is going to be, and they're getting reimbursed by insurance companies, are going to be empirically validated. That means that there's been research to support that particular type of therapy. Now, there are other therapies that people will do that don't necessarily have that empirical research behind it, and maybe it's successful, maybe it's not. There's a thing that was going around. I noticed I get a flyer for this tapping thing to help reduce anxiety, and they've got all these complex types of tapping that you do. I've never seen the research to support it, and so I'm kind of a skeptic about it. And I know that insurance companies are not going to reimburse me for using that type of therapy. So that's something you might want to think about if you have a friend having therapy or you're having therapy. Is there empirical validity behind the form of therapy they're using for this particular mental health concern? Let's see. For example, long-term group therapy is good for life skills, schizophrenia. CBT is using that effective for schizophrenia or overall. Systematic desensitization, what I just talked about, good for simple phobias, not so effective for depression. CBT, good for depression or anxiety, OCD. Behavioral therapy, good for some forms of anxiety, phobias. Some things that we're doing with technology is kind of interesting too. Virtual reality has been really helpful with PTSD. EMDR is really helpful for PTSD. And the new thing they're going to is online therapeutic environments, and that's going to be interesting to see how that pans out down the road. Combined approaches, drug and psychotherapy. Drugs modify debilitating effects. Therapy can learn new techniques. So if somebody's got like severe depression, they may be too tired to come in to get treatment. So that medication is going to give them the help to get up, to go into therapy. And then while in therapy, they should be learning strategies to help them to manage their depression. Integrative therapies is just an eclectic approach where I'm going to use maybe somebody won't just use cognitive behavioral therapy. They might use EMDR with cognitive behavioral therapy, depending on the client's needs, patient's needs. Mindfulness training psychotherapy, which is just a bit of, it's about restructuring one's thoughts, very effective, kind of falls really into cognitive behavioral therapy. DBT, or dialectical behavioral therapy, is what they call CBT, mindfulness without meditation. So DBT is typically used with individuals that have borderline personality disorder. It's been really very effective for them. ADHD, drugs and behavioral therapy works. CBT, prolonged exposure, reduces symptoms of PTSD. But I've had some clients that cognitive bringing back up can be really challenging for them. And so I personally would not use CBT for somebody with PTSD. EMDR seems to work better for that particular individuals with that challenge. Mindfulness-based cognitive therapy, again, prevents relapse during depressive episodes. DBT, again, very effective for borderline personality disorder, eating disorders, conduct disorders, domestic violence. And that pretty much, guys, that finishes up the chapter. It's just an overview of chapter 16. I hope that it's helpful for you as you delve into this chapter. And again, thank you so much for your hard work in class. All right, guys. Thank you so much.